Whenever we work with the fascial system of the human organism, it is helpful to be aware that it's a sort of a very basic approach at the beginning when we start working with a person, and then there is a more advanced or a more refined approach. And I don't like the word advanced so much, but perhaps it would be better that we say we work in a sort of modality which is able to make finer and finer distinctions, and that's advanced work. So we will show a way how to evaluate the shoulder region, but we have to be aware that this evaluation usually has to be combined with another evaluation, the evaluation of the way how the curvatures of the back, the curvatures of the spine, actually also the curvatures in the sacrum and inside the cranium, how those curvatures are related to each other in space and how they act in space while we move. So the areas of junctions between the different curvatures, like thoracic curve, counter curve in the lumbar area, counter curve in the area of the sacrum, or lordosis of the neck, and then kyphosis of the posterior cranium. The areas of junction between the curves, or the areas, the spaces of transition, they have to be evaluated before we go to the evaluation of the details. And in the same way, we have to look at the way how the cavities inside the trunk have junctions or spaces of transition. For example, the abdominal area on the level of the diaphragm has a junction with the thoracic area. The thoracic area up here has a junction with the space of the neck, and the inner space of the neck has a junction with the cranium. On top of that, we have to be aware that there are subdivisions of spaces inside the trunk, like for example the abdominal area where we have the liver, the stomach and some other organs and many nerves and vessels, and then the retroperitoneal space, the space behind the peritoneum with mainly the psoas, the kidneys, the supportive fat of the kidneys and some other structures, and then the subperitoneal space, which in the man contains the bladder and the prostate, and in the woman it contains the bladder and, in a different spacious arrangement, the uterus. We may work intuitively, but our evaluation cannot happen intuitively. It has to follow certain rules. And when we want to understand a dysfunction of the shoulder, and if you want to help a client to use his shoulder in a more appropriate way, in motion, in all-over coordination, we need to combine the all-over analysis, the visual analysis that we use in structural integration, with certain precise tests. I will show in this movie only the very simple items. It's good to do very few tests and know how to do them very, very precisely. That's more helpful than performing many tests, in my philosophy. So, we will evaluate the articulation between the clavicula and the sternum, and we will also test the passive motion capacity of the shoulder region on both sides in connectedness with the arm and the thorax. It is important to be aware that there is a difference in an approach where we try to have a linear effect onto the flexion and extension balance of a muscle, for example. It's important to know that this is different from a spacious evaluation of movement. The psoas muscle is a very, very good example how the muscle activity is connecting with the dynamics of inner spaces of the pelvis and the abdominal area. It runs down the side coming from the lumbar spine, and it has to cross this bone here and then ends on the lesser trochanter of the thigh. Now, when you look at that, you will realize it's not very linear because it takes two different directions. First, the muscle comes down like this, then it has to cross the bone like that in space, and then go here in posterior direction to the lesser trochanter. Now, this is the original pelvis of a female organism more than 150 years old. And you see that the ligaments, those very, very strong ligaments, are still present here, the sacrotuberous and the sacrospinous ligaments. Those ligaments are not running down in a linear way. They have a spiral-like torque into them, which is usually not shown in most of the anatomy books, because on the cadavers which we use in dissection to prepare the drawings of anatomy books, you cannot see that so well many times. But here it's very, very clearly that is a sort of a twist. It's a non-linear force transmission that acts between the sit bone and the sacrum. Now, coming back to the psoas, we have to be aware that this muscle, the way how he acts, is not only dependent on its own muscle activity, it's dependent on the way how in the retroperitoneal space the kidney moves with the breathing motion, and how dense or how fluid the supportive fat of the kidney around the psoas is in reality, because that has a big impact on the way how the kidney can slide down and upward 20,000 times approximately a day, following our activity of the respiratory diaphragm. So, all this here, the interaction of psoas, flexion extension, or of sort of a partial spasm of a subdivision of the psoas, they may have an impact on the mobility of the shoulder. Actually, the way how the hip axis is in place, the way if the tendency is here that the pelvis tilts backward all the time or tilts anteriorly, it automatically, when you look at myself, it will have an impact on the way how, in a postural attitude, our shoulder will relate to the all-over tensional pattern of our body. The way how we move and the way how we orientate in a tactile way or using our eyes in space. So, to understand that, what finer and finer distinctions can mean, we have to be aware that our treatment has to respect the larger units of the organism and recognize them in space, as well as the very, very small units. And in practice, what we do in a manual field, it is actually not that much stretching some fibers. No, it is more talking to the fluid balance between collagen fibers and extracellular matrix, and on the way of the nervous system and the brain, it is more a sort of an awakening, a sort of, if I may use that word of the great therapist and innovator, André Pilat, it is sort of an induction. Whenever we work with a fascial system, we have to be aware that there are different modalities to evaluate what is going on with the organism of our client. In structural integration, we traditionally use visual analysis. We watch the person in sitting, in standing, in movement activities like walking. We see how the contralateral motion of the shoulder girdle, the arms, correspond with the motion in the hips and the lower extremities. We look at people when they move, and we look when they sit still, and we make a certain evaluation. In addition to that, we can evaluate how certain parts of the body move in passive motion when we use certain tests. And we can combine that information with the visual analysis information. For example, we may see that this shoulder is somewhat different in space compared with the left shoulder. And this observation we compare with that what we can feel in a palpative test where we use our hands to collect information about the motion capacity or the motion restriction of certain units of the body and their interrelatedness through the fascial system. The first test what we want to do to collect information about the function of the two shoulders is, and that's the shoulder is just an example, we may do it with other parts of the body also. The first test is that our client gives me his right hand and I asked him to be as passive as possible, and I see how I can move the arm backwards posteriorly, and I also touch here at the junction between the clavicle and the sternum, and I see what kind of passive motion happens here when I turn the arm, the upper arm, and I move the arm. Let go of the arm, please. It's important that the person can let go of the arm. If the person cannot let go, it's difficult to perform this test. But he's a very sportive person, he's a professional soccer player, and he knows how to let go and has very good coordination. Now, what I do is I perform the same test as on the right side, and I realize I cannot move posteriorly the arm as well as on the right side. And also when I make this turning motion here, I see that here, on the level where the clavicle connects with the sternum, that on this level there is a lack of motion. So my suspicion is, together with the visual analysis about the position of the shoulder, which is a little bit more downward here, together with this evaluation, I get information using this test that there seems to be a restriction on the level of the junction between the clavicle and the sternum. In addition, we do another passive motion test where we observe the global junction of the shoulder girdle with the upper arm and with the thorax. For this test, we give a sort of a gentle push that goes directly in the direction of the xiphoid process. It's not that way, it goes that way. And we check the passive motion, and on the left side I realize there must be sort of a dysfunction because there is a sort of a strong resistance here. I can push and there's an immediate response, and here he can feel it himself, then there's a sort of a restriction. Sort of a dysfunction. Now, what we have to be aware of is that this dysfunction has to be seen in the context of the subdeltoid fascia, which goes underneath the deltoid muscle here all the way around, and it's an arrangement of a whole list of different fascia layers, starting with the fascia infraspinata, continuing with the fascia of the teres muscle, continue it under the deltoid muscle with the fascia especially of the subclavian muscle, which is very, very important. So we can imagine on a fascial level, there is a sort of a grip around that, like two hands are holding the shoulder, in his case here on the left side, a little bit too much against the thoracic cavity. Now, however, we have to be aware that there are other components which can play a role, which are not localized in the area of the shoulder. I put my hand now onto the abdominal area for a certain reason. I have to be aware that the dysfunction of the shoulder is usually to be seen in a larger context of tensions all over the body. And especially it has to be seen if we have a big right-left difference inside the deep cavities. So when we look up here, this whole tensional pattern of the subdeltoid fascia is sort of a linear relationship. It's fairly complex, but it's still linear, and it does not give information about the spacious components which have to do with the inner spaces of the abdominal area, and especially the space, the so-called retroperitoneal space, where we find the psoas and the kidneys. And when I put my hand very, very relaxed here in a sort of a local listening attitude, as Jean-Pierre Barral has developed it, many of you know about his teachings, I will feel that my whole hand very gently tilts to the right, to his left side, very, very deep, pretty close to the midline. If I try to relax my hand and induce it to his right side, it does not happen, but it passively follows my hand. My listening hand is attracted very, very deep, very deep. Because it's very, very deep, this attraction comes from very deep, I'm quite sure it must be around the kidney area and psoas area, and not from the duodenum, because the duodenum is more anterior. So I'm pretty sure now that in this test here, when I look for the space between the 12th rib and the crest of the ilium, then on his right side we have sort of resilience. He can go easily into a lordosis with his spine. If I do the same here, there's a resistance felt in this area. And this kind of resistance shows that there is compression on the left side of the psoas area of the left kidney. And to help the shoulder, we would have to treat that at first. When we look at the legs of our client, we see that the whole left leg has a tendency from the thigh downward to rotate a little bit externally. This may be or may not be a sign that the left psoas tends to be a little bit too much in flexion, and as he is a professional soccer player, it's always critical for him to see that his left hip area is not too much under compression. So the first part of our treatment for the shoulder would be to treat the larger context by asking him to raise this leg and put his foot up here on top of that. What we do now is we support the area between the 12th rib and the crest of the ilium, but we are immediately underneath the 12th rib. And what we ask him to do is, we want him to guide his own psoas in a sort of a very relaxed attitude into flexion and extension. And we passively help him to find a larger amplitude for extension of the psoas. So when he lets his pelvis tilt to the left, we ask him that he extends in a relaxed way his left leg, and then he rotates the whole leg internally, and then he will pull his leg upward again while the heel is heavy on the table. We support this motion with a subtle compression of the space, the retroperitoneal space from posteriorly, and we do a very subtle stretch indirectly on the 12th intercostal nerve that connects with the kidney, and the 12th intercostal nerve, pull the leg up again, is embedded in the fascia of the latissimus dorsi. The fascia of the latissimus dorsi also on its upper end, now put the legs again like this, the fascia of the latissimus dorsi is very, very important also on the upper end in the shoulder region, because it connects with the fascia of the teres major muscle before it goes inside the joint connection of the shoulder. What is important to know is there are many small units of the so-called subdeltoid fascia, but they all connect and they end in the front at the junction of the clavicle and the sternum, the clavicula and the sternum. And we go with the supported index finger here, it's supported by this mid finger, we go directly in this small triangle between the first rib, the clavicula and the sternum. And we have the chance to have an influence on that level to many layers of the fascial system at the same time. So we are not only aiming for the subclavius muscle, for the fascia of the subclavius muscle. No, we are also aiming for the fascia of the end of the scalenes that go down and who have a connection to the suspensory ligaments of the lungs. So we also have an impact on the suspensory ligaments of the lungs, also onto the endothoracic fascia, which is sometimes very fibrous in this cranial part of the thorax, and also the two layers of the pleura, the visceral layer and the parietal layer of the pleura. So we have the chance to have an effect of 7 different kinds of fascia, myofascia, and ligaments and membranes, at least 7 of them at the same time. And how we do that is we go directly to the junction, the triangle that I described before, and our contact goes through the tissues, directly through the body, way up to the ceiling. And we ask our client to relax more and more into that contact, and after a while we will ask him to take a deep, deep breath that he inhales and exhales, and I can feel how the scalenes react with contraction and flexion and extension in that area. And I follow with my hand, with my contact, the motion which I can feel deep inside. For example, I feel now a clockwise micro motion, rotation in that area. I follow that micro rotation and exaggerate a little bit. And on top of that, I take his upper arm, now let go of it, and I shear, gently shear. I add some compression into that space that is supported of my fingers. So actually what I do is I add some compression to the joint capsule, and at the moment where I feel the humerus wants to go, can you feel that? Float away. From the thorax, I let it float away, and I may do it a second or third time to actually compress the joint capsule, compress everything, while I hold my contact through the spaces. This is a non-linear approach. We work with the linear tension of tissue together with the compressional reality, the hydrostatic pressure reality of the upper part of the inside of the thorax. What is important is we may work intuitively, but we are not allowed to evaluate intuitively. The evaluation always has to follow very clear rules. So remember, at the beginning we tested the passive motion of the right shoulder and compared it with the left. And how does it feel now?
It feels a lot better.
So the range of motion of the left side is actually better than the right one now. It's not a good idea to also correct the right one now, because it will be confusing for the movement cortex of the brain. And the message that we work just on the problematic shoulder is more clearly for the brain, and we will have a better result. It is very important to see that there are two aspects essential for this kind of work. We have the macro structure, the bigger, larger units, like for example the fascia of the latissimus dorsi. But then we have the details, like for example the 12th interthoracic nerve, the psoas amplitude of flexion, extension, but then we have the very, very details, like for example here the local details, like for example the ligaments between the sternum and the clavicula here, and inside the joint capsule. And these small units are connected with the larger units, and the larger units are connected with the smaller units, and they are embedded into compressional forces of the cavities. The more clear we are with our touch, it has to be neutral, but very clear and very decisive, the more easy it is for our friend, very deep inside his brain, to understand the message that our touch has to give.